Okay, so I got a few new questions. Nikki, you have the most cards, so I'm going to start with you. In which trimester of prenatal development is a baby most impacted by maternal stress? That's a great question.
It's the billion-dollar question. It depends on the paper you're reading. So I will say that there does seem to be some developmental outcomes that may be more sensitive to the earlier parts of pregnancy, others that are more sensitive to the later parts of pregnancy, but it's not super consistent. And because human data is flawed and the message gets confused when you tell people to worry about a specific trimester, I just like to say we need to promote the health and well-being of pregnant people throughout pregnancy and preconception to optimize their and their offspring's health.
So kind of a related question. Now that we see how mindfulness-based stress reduction can improve outcomes for pregnant people through babies and beyond, do you have thoughts about how we can implement this in clinics and in therapy sessions?
I think, one, it was great to hear Carissa mention mindfulness. A couple other people have mentioned mindfulness today. In passing, there's a lot of folks out in the lobby talking about it. It's happening in schools. I don't know, Adrian, if that's something you guys work towards. Probably high school, it's a lot of uptake. I think in general, there's an opportunity for our society just to slow down and to practice mindfulness in our day-to-day and to recognize what that does to our physiology. Even like if we all just stop right now, just stop, take like a slow breath in, hold it at the top for a second and let it go. What did that do to your insides?
Beautiful.
What did that do to your thought pattern? And if we can promote an understanding that this high-paced world where we're multitasking, we're checking our phone, and we're talking to our kids, and we're arranging the thing, and we're doing the thing, we're doing the chart note, and we're prior auth, and oh, by the way, the basketball game for your child is on Tuesday, and time got changed, and we don't have the snacks. Right? That's not good for us. It's not good for anyone. And so in general, I think as a society, we can work towards that. That said, there's specific targeted mindfulness-based stress reduction and mindful eating and mindful activity interventions that have a really strong evidence base. The data that I showed you today, it's a publicly available free manual. Anyone can try it. We're talking with folks about putting on apps. I don't think apps are going to be nearly as effective because so much of it was the interpersonal, in-person connection and the relationships that were built. But it's a long answer. Sorry, Jen, I broke the rules. But the goal is for everyone just to understand that this way of being in the world is good for us to slow down, to support others to slow down, and to remind us that we can control our bodies, our physiology, and our stress response. We can control, in some ways, our immune system through mindful practices, and it's worth promoting.
Beautiful. So, Adrian, this was for you, and it just, to me, relates to what you just offered. So I don't know if you want to build on what Nikki just said, but what advice do you have for adults, parents, teachers, coaches to stay regulated in order to co-regulate youth?
Yes. That is such a good one, and I remember talking to one of the board members prior to speaking here, and they said, you know, when do you get the most dysregulated at the school? And I said, when I'm helping the other adults. So all that to say, I can use these tools too. I think one thing that's really important and really ties into what Dr. Bush was talking about was just the power of the pause. So we talk about how the real power is in between the stimulus and the response, and how when we can lengthen that, we can make better choices. That's something I really talk to kids a lot about, and I think adults can really step into that as well. And so then once we're in that space, that allows us to use the tools like breathing, which activates our parasympathetic nervous systems, and Maybe it's taking a 5-minute walk, so that you can choose kinder words. Doing those things that really help you make the best choice in that moment. And then also it's really important, I think, to know that many times in life we are not going to make the best choice, and part of being a wonderful teacher and parent and coach and counselor is modeling what it looks like to repair after harm has been done. So if you have snapped or said something unkind or, spoken in a tone that was hurtful, really owning that and showing what it looks like to have that self-responsibility to apologize and to really mean it, to be authentic in your apology, and to just normalize that mistakes happen. It helps kids to see that it's okay to make mistakes and that it's not the end of the world and that we can try again.
Beautiful. So Steve, I have 2 questions for you, but I'll start with just one, I guess. Do you integrate, or how do you integrate parents into your work? Because I think you mentioned families.
We definitely do integrate parents. I think students would like us not to, but
Fair.
there's a lot of begging. Please don't call my mom or don't. Yeah, but no, it's very important to integrate parents. We have newsletters. We encourage parents to join our Google Classroom so they see their students' progress, as well as we use Infinite Campus at Santa Cruz City Schools. But we also do student success team meetings where we have parents involved with teachers and we talk about student strengths and some of their concerns. We do open house where parents can meet teachers. I think our number one goal, and that's something that we're always working toward, is having more parents involved, either through volunteer work and just showing up. We definitely see that parents who do show up, their students do a lot better in school. So we always encourage guardians and parents to be part of their students' education.
Thank you. That's great. So Ron, we have a couple of questions for you, and some of them were sort of answered just, by your clinical pearl that you gave. So maybe you want to add on some other approaches or strategies. Here, a question here is, what are some strategies to help adolescents to balance their desire for social competence versus a pro-social development, or competition versus cooperation? How do you address that, or what are your recommendations for that?
Yeah, really important issues and a bit complex how to balance
Well,
these.
now you have plenty of time to share it.
So I would say a few things about this. I think that it is, and I actually want to tap back into what Adrian was just saying about making mistakes and repairing. It's trial and error learning, and so leaning a little too much into the competition can cause you to get some, feedback that's that one can learn for, and I think that one of the things for young people that can be a helpful step is there is such a tendency to be self-conscious and focused on yourself. I mean, we all have some of that in our moment-to-moment lives, but I think particularly in young people as they're moving into adolescence. And so whether they're thinking about being successful, competing, or whether they're thinking of themselves as are they earning a reputation as being kind, they're focusing on themselves. What happens is when you can help them come up with a strategy for actually focusing on the other, and first of all, it takes the attention away from, am I making a mistake? How am I coming across? Which is, and the more time they spend on, digital communication where they're curating what they're saying and stepping back and looking, it's a lot of self-consciousness. And I would say it's a lot more like learning a sport or learning how to be in a theater group or learning how to do group activities that come up over and over again. Interacting in dynamic ways with each other, I think, is really a key part of these skills. Mindfulness and taking a breath and slowing down is wonderful, but a lot of life happens at a fast pace. And if you don't practice navigating in real time, what to say, if somebody, like, it's hard to be witty, it's hard to take a risk of being funny, it's hard to be quiet and let everything go by. And so I think part of this is more like learning a sport or learning how to, do an art, and it requires interacting in a group and getting support and practicing. And what that looks like in 6th grade is different than it might look like in 10th grade. It might be different than it looks like in senior. But the principles of practicing and getting feedback and getting help and support from adults, I think that's the general approach. And then you can slice into that. For some young people, they have particularly difficulty with being really anxious, socially anxious. Some of them have a tendency to react quickly, aggressively. I think that how to tailor this for different kinds of skill development can be important as well.
Thank you. That was helpful. So, Nikki, this might be a shorter one. When scoring your ACEs, the adverse childhood events, is there an age at which, kind of a maximum age when you're counting your ACEs? How does age interact in the calculation of ACEs?
So typically, there's hundreds of ways to think about ACEs, but the most commonly used one is to say before the age of 18. Although some of the data I showed you today was focused on experiences before the age of 13, and I just didn't have time to get into all the nuance. But we do find that exposure at the very youngest ages is more powerful, potentially, but again, not deterministic. However, really, if you're 18 years and 1 day, is it stop mattering? No. It's really just a metric to stop at some point and think about it. But really, adversity in our 40s can really harm us, but we have a lot more life experience. Our bodies are much more developed, so it's less likely to have the same type of health impact as it would have had if we were, say, 12.
Thank you. And then related to the ACEs, this questioner had a lot of complex kind of issues in their question. So forgive me to the person who wrote this question, because I'm going to kind of move through it in several ways. So the person is curious and commenting on the rise of the white supremacist movement and how you see that interacting currently in both the collection of ACEs and the interpretation of ACEs, and maybe even, because I've seen a change in how we describe ACEs, and there has been an evolution towards including social factors, whereas the original ACEs didn't include anything about poverty or housing or employment, those factors. So can you share with us a bit of your thoughts about the rise of racism, discrimination, et cetera, in the calculation of ACEs?
Sure, I can try, and I'll try to be succinct. That's a big topic. In short, ACEs got really popularized 20 years ago by some people in pediatrics, but really we've been studying it officially in psychology for more than 100 years. And what I love about psychology is it's long had a much broader lens on the various layers of individual development, family development, school, community, macro, meso systems, like the layers that go out, society and politics and policy and zeitgeist that all influence the probability of being exposed to challenges or having the resources to operate from a place of strength, resilience, and coping. And so ACEs are very useful because they are well understood. You can now be reimbursed for screening for a particular set of ACEs. Now there's a PEARLS screener in the state of California that includes socioeconomic status, food insecurity, housing insecurity, in addition to kind of the classic 10 that I showed you today. And our research on the PEARLS, I forget what it stands for, I should know that, really shows that all of these factors, and I tried to highlight some of that today, so socioeconomic adversity itself is really an ACE, even if it wasn't on that original chart.
Exactly.
I mean, it's underlying the risk for so many of those factors, and often places people in a position to where the caregivers don't have the time or energy to provide that buffering environment that they'd love to provide. And I also just want to say that caregivers who are depressed or stressed or low income sometimes are the best caregivers. So do not hear that I am saying otherwise. I'm saying they have to work 10 times harder to be that optimal parent sometimes, and they just themselves are often quite fatigued at the end of their second shift of the day, et cetera. So I bring that up, but we've definitely seen a shift in who is experiencing challenges the last year and a half. I mean, I have had to change what I say, who I say it to. I've had talks canceled. I've had my research and my team's research delayed and canceled. I've had a lot of, it's been a struggle. And what I gave you today was a really watered down version of what I usually do because it's being recorded and it's being placed on the web. And my employment and my funding is jeopardized when I take risks. And I still took them today, but I did it much more conservatively than I used to a year and a half ago. And I think it's something we need to acknowledge, and it's something many of us are fighting and will not stop fighting. And I do think that there are things such as the Epstein files. I mean, talk about violence against women, talk about terrible things in our society that are related to power and gender and lack of accountability. And there's so many layers. The racism is a huge component. And I mentioned it lightly today, but, chattel slavery, colonialism, these things are really pervasive. And yet some of those communities are some of the most profoundly resilient, authentically empowered, beautiful, cohesive, rallying forces for wellness, for each other, for individuals, and doing the work that so many of those in power should be doing to undo this stuff. And so I am now on a tangent. But my point is, what is ACEs? What does it include? Is it worse? Yes, it's a lens that's constantly changing. But what I love about being a Californian for the last 20 years, and especially recently, is that we're looking at it, we're naming it, we're articulating, we're fighting, we're putting in laws, protections, and we're part of the resistance. And I'm glad to be here with you. And I think we can make health happen through understanding the roots of health and the solutions. And just like adversity harms, connection, positivity, community, support heals. And I think that's the piece I didn't have time to really emphasize at the end of my talk, so thank you for giving me the mic again. We need to not just focus on the power of social to harm, but the power of social to not only heal, but promote health.
Beautiful. Wow. So there is a related question about how we can, what we can do to support changes in California in terms of policy, but I'm going to just pause for a second because that was a beautiful summary, really, of some of that. I'm going to move to Carissa. There I see you, hi. So emotional regulation has been raised a number of times today. What's something you lead with in your DBT program with teens to facilitate the building that skill of emotional regulation, such as maybe anger or something like that?
Yeah. So what I typically start with is really just normalizing emotions and helping them to see that there's nothing wrong with having them and that it's human to have them, it's human to get angry, and providing that education and information, doing some interactive activities, talking with them about what exactly makes them angry, or sad, or whatever it may be. And then also maybe looking up different feelings together if they don't know what one means, maybe like shame or something. Just being very curious and providing a lot of information. and then moving forward to build tools on top of that. So how do I actually cope with this feeling when I am angry, and what are factors that contribute to me feeling angry? Is it because I mean, going back to like the sleep and stuff, did I sleep poorly? Have I not been eating? What are the things that are making me vulnerable today to why I'm feeling this way? Or is it something kind of specific about this situation, or did someone cross a boundary of mine? So all of the modules and skills are super related. So really finding, like with emotional regulation, if you're mad about something, it's typically because someone crossed a boundary of yours, or you have not set a boundary yourself in that situation. So helping them to build all those skills, and yeah, that's it.
Thanks. There's so many interesting aspects of trying to support healthy emotion regulation, and you've been involved in a number of studies. And I think that just to unpack this a little bit, I'd love to hear other people's thoughts, because it's so central to a lot of helping young people navigate effectively in their lives. Is sometimes there's this naive tendency to think emotion regulation is you've got to hold your emotions down. You have to take some top-down pressing and keep that emotion down. And emotion regulation isn't usually regulating your feelings. It's regulating the behavior related to your feelings, number one. And so helping shift to, well, what behaviors? Yes, you're feeling this. And then the second thing is, a lot of times, what is an effective strategy to regulate your behavior is to shift your feelings. It's often easier to activate a different feeling than to push down a strong feeling that's coming up. So for example, curiosity is a great feeling to activate. Because it's kind of neutral. It's like you're not pulling away, you're not avoiding, and you're not aggressive. Like to shift to, why did that person do that? Or what could I do in this situation? So it's a strategy like shifting your feeling, and again, depending on the individual and what they're trying to do, the goal is to control their behavior so they can make good decisions about how to treat someone or repair or change their behavior to meet their goals in the situation. But if they're just trying to push down one feeling, that often isn't the best strategy. And helping them come up with their own versions of, well, how might I shift my feeling to something else? And curiosity is just one example of a nice way into a different way to navigate that situation.
Can I just add to that? I think so much of it, especially like after listening to the youth panel and working with kids, is that it's the systems around them that tell them that it's not okay to have that feeling. And so whether it's a parent who's overwhelmed and they're in the store and everyone's looking at them and it's really the parent's discomfort that's the issue. And so much of the work that I think that I do, and probably everyone else in this room, is providing a ton of psychoeducation about what that looks like to support kids who are having feelings. And it's okay to set a boundary, and it's okay for your kid to be upset about that and create that space. Like, okay, I get that you're really angry. I'm not going to change my rule. Because I think parents are like, well, you just want the kid to be able to get what they want. It's like, that's actually not what I'm saying. Let me help you understand it from this perspective of you get to have that boundary. You're the parent and you get to decide what's okay. And your child also gets to have their feelings. And so what does it look like to hold those two things and create that space to be able to do that? And I think that's so much of the work that we do. So the kid is my client and the parents are also my clients.
Beautiful. Yes, something to add, please.
I really appreciate what everyone's saying. I think in the school systems, sometimes it can be a little different. I have students who are Latino or students of color, and the thing of race comes up, and the reactions might be different, and teachers' reactions might not reflect how the students are feeling, right? So I actually have students who are bringing their birth certificates to school just in case ICE shows up, or how to and some teachers don't get that feeling. They don't know why, what's the big deal? You're safe, but it's different. And so I think that actually the cultural piece of it plays our need to be flexible with what feelings might look like depending on special populations, has to be respected in that sense too.
Okay, thank you. Really important. Returning to your program, Carissa, there's a question kind of about the penetrance, or like what percentage of youth who have been hospitalized and come home in Santa Cruz County are able to benefit from your program? Who are the kids that are left out? Or is anybody left out? Or you got 100%? What is it?
I don't actually have that data, to be honest. But I also am an access clinician, and I do a lot of other things. So I would say it's just started about a year ago. So my sample size is relatively small, but I am interested to continue working with folks, and I'm about to take on a few more. I would say just like an estimation and no actual numbers, maybe like 80%. With that being said, that are not in like going. With that being said, they do have services and they do have supports. So that's just something to keep in mind, right? Like they do have access to individual counseling, psychiatry, intensive home-based services. There are a lot of other additional services with actually a lot of counselors that are here today in this room that provide amazing quality care, and some even utilize DBT skills too. So there's that, and then we also do link even private insurance families to services as well. So yeah, I wouldn't say that no kids like left behind, but all the ones that I know that my team knows about, we're reaching out and we're connecting them, and at least connecting them with somebody or some kind of service. So in that kind of sense, nobody's being left behind in that way.
Got it.
Yeah.
Okay, thank you. And do you need more PR about this? I mean, does everybody here know about that program? No. Okay, so this is your advertisement. So, and do they contact the program through you or through Access? How do people find out, get linked in?
It's just post-hospitalization DBT program, whoever said that. And then in terms of getting in contact, I would say, to contact me directly. I do have to coordinate with my supervisor to ensure I can take, so many cases. But yeah, definitely happy.
And is it just you doing this program, or are there other people
right now,
providing it right now?
Is it only in North County or South County?
What was that?
I do provide it in North County and South County because I float between our offices, and I also have done it via telehealth before. So it kind of just depends on what day the youth is available and what day I'm in whichever office. And then if anyone wants to connect after, you can please come up to me for my information.
What was that?
Is that for county behavioral health?
No, she said that took some private as well.
No.
Yeah.
Oh,
No?
so no, sorry, no.
Oh.
Yeah, it is for county behavioral health only right now at this time.
Oh, but what was the thing about private insurance?
That because through Access, when we have youth that, let's say they have Anthem Blue Cross or something like that, and I'm notified of their hospitalization, then we do reach out to the family and provide them with a list of insurance resources for the parents to reach out and connect to, like Coastal Turning Point, for example, that's here today, or to Shine a Light, or other agencies in the community.
Thank you. Great. So Zach, we have a couple questions about your rocks. Yeah. So they're kind of interrelated. Let's see. I'll start with one. How do we name rocks safely? Or actually, it's the kids who are naming the rocks, I think. So we are mindful of dysregulating students during the school day. Yeah, and then to help them heal.
Yeah, it's a great question. Obviously the kids are the ones that are naming them, so I let them know that they can call it whatever they want. If it feels too difficult to put like the name, they can put initials, they can put some sort of a code word. So sometimes like I'll get SA, which is for sexual assault, or they'll tell me like grade 7. We're just gonna leave it at that. So they get to decide. I don't even ask them in that moment, like what that means. So they get to come up with their names that feel appropriate, and at a certain point during our therapeutic process, we'll get there. In terms of the school day, I'm really mindful about the kids that I'm going to do this kind of work with if I'm working in the school setting, and I will see them at the end of the day. So I am not going to send them back to class if we worked on even just identifying those things. I'm not going to see them at 10 in the morning. I also try to see kids in my office, like outside of a school setting, but if I have to go to school, I do it at the end of the day. I've alerted parents so that they know that their kid is going to come home and that we've maybe brought up some feelings. Especially if I'm going to do EMDR with a kid, I also will always let a parent know that I've done this work, and that they can expect that there might be challenging feelings or behaviors in the next few days. So yeah, I try to be really, really mindful of any trauma work that I do.
Thank you. And then, just since we're on the topic, I'll continue a little. Do you ever see a pattern in the rocks that then that they write down that then you sort of, it takes you to a particular place? You want to talk about that?
Yeah, and I love with my older kids will note it themselves when they can once we get to that place and they can kind of lump them together, which is really lovely. Or if they don't get there, I might kind of put them together myself and say like, hey, I've noticed. And a lot of times it's this like, oh my gosh, you're absolutely right. Or they'll write something down and like, I didn't realize I've been holding that what happened to me when that teacher said that when I was in 7th grade is still bothering me and I'm 18. So it's amazing the kind of stuff that comes up. And yes, there are definitely patterns around the lens that they're looking through, and so then things start to like attach. It's almost like Velcro.
Thank you. Yeah. So back to you, Nikki. One of the questions here relates to a curiosity about the specific child-parent psychotherapy intervention, and if you could describe that for us.
Sure. So child-parent psychotherapy, or CPP, is the therapy I shared for infants to age 6, and it's for families where the children have been exposed to a significant trauma, but usually if the child's been exposed to something, the family has been, although the child is the identified patient initially. And the therapy is a really beautiful, relationally based therapy rooted in psychodynamic attachment therapy, but really focusing on naming the trauma, addressing it, helping the caregiver see that the child also experienced the trauma. Even infants have physiological and behavioral responses to being adjacent to trauma, and a lot of parents are really unaware of that. Most people in the world are unaware of that. And helping them identify the behaviors and the reactions of the child through the trauma lens. And more importantly, to help the caregiver see that sometimes their reaction to their child is also influenced by their own trauma, and or the fact that maybe that child reminds them of a former abuser, or, there's so many layers to traumatic experiences and environments. And so they really just name it. And they say, and that makes sense given what you went through. And then they help model relational conversation through play-based therapy with the child, with the caregiver, transition that they hold space for the caregiver. But important to all of this is they make sure that the families are safe. So there's a case management component, make sure they're housed, they deal with those basic primary needs before they dig into any of this too much. It's really hard to do the work on this stuff if it's being re-experienced. And so therapy is just a beautiful, intensive therapy, but we found effects. It's usually like a 20 sessions-ish, give or take, but some of the families that I showed you data for only came to 8. Some continued on beyond the 20 sessions that we assessed, but it's very powerful. And we really, one thing I'm very proud of is one of the reasons I did the work is because the work that you guys do, so many of you in the room, even the youth, the work you do on your groups and your teams and up here today, it doesn't just impact mental health, but I wanted to demonstrate that an improved biology that's relevant for a range of physical health outcomes. And guess what? Mental health is health.
Right.
We just split it for whatever reason because of stigma, but it comes from our body. Our brains and our minds are part of our body. Our experiences affect our health, and our health experiences our mentalities and our behaviors. it's really the same thing. And so I wanted to demonstrate that this psychotherapy, play-based, relational-based supportive attachment intervention improved biology in a way that is likely to reduce risk of asthma, obesity, heart disease, cancer, you name it, suicidal ideation, all those things. And what's great is it's now an even higher evidence base because of these data over the last several years, and it's reimbursable by more and more and more payers. And that is some of the work some of the goals of the work that we do, and with the mindfulness-based pregnancy intervention, the goal is to demonstrate its efficacy so more people pay attention to the value of psychotherapy, more people see the potential economic benefit. I mean, I do it because it's the right thing to do, but some people are motivated by other things. And so if we can show the health benefit, the social and economic benefit of providing these things in the event of adversity, then we can get more stakeholders to say, we gotta pay for this. It's gonna save us a lot of money at the end of the day, and it's gonna make our population way better.
Yeah, beautiful, thank you. So, Ron, Dr. Dahl, this person is asking, what age, I think, range or age frame might be most at risk for beginning signs of mental health distress, and how might the symptoms appear? That's a broad.
That's a very broad.
Broad
So
question.
the question is about mental distress.
Like, when are you seeing a rise in mental distress? I mean, I guess
So
I'm thinking of your slides, but I think that we didn't have one exactly on
So I
that.
think I'm going to say two things, maybe to be helpful in this. I think one is that inflection point wasn't that there's something magical about age 10.
Right.
Rather, there's a set of processes as the early stages of puberty are kicking in and the brain is changing, the bodies are changing, that there's dynamic changes across multiple levels, brain and body, and how feelings are activated. And that creates mainly opportunities for learning new things. But those rapid multi-level changes mean that the interactions across many levels of as shown in some of Nikki's slides, that these different processes for regulating all of our behavior, whether we eat, breathe, have emotions, connect with people, these systems are undergoing change, and that can spiral in negative ways. But having some level of distress is pretty normative
Right.
at almost any age. Distress and how to manage the distress through the people that support you. As you get older, increasingly your own strategies. And so I think it's not that. And then the second thing is, and I want to say this to invite us to think creatively. I don't like the term mental. I don't know when we use the term mental and why we call it mental health as opposed to health. And are we talking about the brain? Are we talking about psychological processes? Are we talking about behavioral processes, emotional processes? I know what behavioral health is. I know what emotional health is. Mental health. Why do we use a term mental? And we don't mean specifically neurologic. And so it became a term to avoid stigma that has basically just created new kinds of stigma. And
Amen.
So could we say distress?
Yeah.
I mean,
yeah.
And so again, it's not to pick on terms, because I use the term all the time because that helps connect to mental health work and mental disorders. And the words matter because they affect these conceptual frameworks. And a more integrative approach to understanding healthy ways, adaptive ways to deal with distress is fundamental to learning and adaptation and resilience. And when that starts to interfere with functioning and spiral downward, can happen at very different ages for different kinds of issues. But a lot of the mental disorders, anxiety, depression, eating disorders, a lot of those start to emerge around the time puberty is starting, statistically. But of course they can occur any time in the lifespan. But it helps us think about not just when are these developing? But why are they more likely to emerge in society, in culture, that create these negative spirals?
Thank you. Beautiful response. Thank you very much. So another sort of broad question for you, Nikki. Autism or ADHD, just looking at that whole realm, we know has a high genetic component. And this person is asking, could it also be caused by sort of parental exposure to stressors? So how do you look at those two components, the genetic and the kind of environmental factors?
Yeah, I think our field is constantly evolving. You know, science is real and good, in my opinion. However, it's an evolving understanding with the lens that we have in 2026 and the biological awareness we have now and the zeitgeist we're conducting it and who funds what and who cancels what. And so we do the best we can, and it looks like there's certain mental health challenges that are particularly hereditary, meaning that if you have one or more parents with it, you have a higher likelihood of having it yourself. It's not deterministic. But there's social, nutritional, and chemical exposures that increase or decrease your risk. So smoking during pregnancy is a very big predictor of ADHD, for example. Whether or not your parents have ADHD, but if your parents have ADHD and you smoke in pregnancy, then it increases the risk, right? And not just in an additive way, but in a more kind of interactive, compounding, exacerbating way. And so stress is similar in that if you have a propensity to have impulsivity or inattention, and then during pregnancy, there's a lot of stress activation in the pregnant person's biology, and that's cueing the fetus come out kind of ready to go because there's a lot going on, you gotta be ready. Then that child is more likely to be hypervigilant, have a lot of energy, maybe have trouble sitting still because they're ready to survive in a world of intensity. And so it's this dance of genetics and environment that explain the vast majority of health and disease outcomes. And I think historically, a couple decades ago, there was a big push for genes are going to be the solution. We're going to do the genome. We're all going to know exactly what's going on. Well, guess what? We still barely know what we're doing. Same with the microbiome. Same with epigenetics. You know, it's going to be the answer. I showed some today. It's not the answer. It's just another lens that we're trying to use to pinpoint some understanding of what's going on and have a little bit more of a confidence that we're seeing something real, because so much of psychology and mental health has always been like caregiver report. And sometimes if we're lucky, teacher report, but you guys are so busy, it's hard to get you to fill out forms, totally understand. But now we have this under the skin stuff that lacks some of the stigma, right? So if I ask all of you guys to report on a kid, you might have a bias. You know, Adrienne might really want George to get some services, so she's gonna say he's not doing so great, but you know, obviously Adrienne's very ethical, she's gonna tell the truth. But someone else might not believe Adrienne's report, but if we can show that George's stress biology across a range of systems is elevated due to adversity exposure, people may take his needs more seriously, especially because those stress elevations are related to a range of physical health outcomes. So even if they don't care about mental health, they might want to do something for George. And so I think, God, I lost track of the question, but
That's okay. You're good.
What was the question?
I already turned it over, but yeah.
ADHD,
Basically,
autism.
just talk.
Yes,
you're
there is
doing
a
it
genetic
perfect.
liability, but boy, it is an interplay, and we still can do a ton with folks who have a strong genetic loading. We can do so much as a society, as a community, as individuals, as parents, to really buffer the demonstration or activation of those symptoms.
Thank you.
Thank you for that help.
So, Ron, you mentioned working on Zoom, and do you have any tips for us, and actually anyone else can answer this as well if you have tips, on telehealth or tech to overcome the tech barriers, to really embrace connecting with others and with feelings?
Yeah, there's a whole set of things in that space, including how young people are interacting with each other. What do we lose in this space that we've all been talking about relational connection, about authentic connection, about picking up these subtle cues? I think that to give a brief answer, we need to know a lot more. I think that the principle of finding ways to create the feelings and authentic connection is the principle. How to adjust the aspects of the interaction to make that more likely to occur. So it's one thing if you are interacting with someone you already have a relationship with. We know that. There's a lot of data about that. That's easier to do. If that's not there, how to do something that creates a little bit of breaking the ice and a little more vulnerability to make it feel more authentic. Relying on other people. Sometimes what we've been doing with our work isn't interacting with young people directly. It's interacting with the people who are going to be working with those young people. And again, some of this is language. A lot of what we've been doing in these studies is teaching clinicians and caretakers in Ukraine with what we're trying to do, training young people who want to learn how to do it, and then they're implementing it. So it's basically, we're really using the technology not to have one-on-one interactions, but rather to
teach,
facilitate real interactions that are going to be culturally appropriate, they're going to have the language, and so that recognizing we would be really limited. So it's really interacting with even a trainer of clinicians. So we've been using strategies like that. And I do think that there's a lot of uncertainty about what is lost when we don't do this, and that young people, it's not to just blame technology and phones and text, but I think these are empirical questions. The brain expects a lot of nuanced, synchronous interaction, because that's what happened throughout human history. And some of that can be activated with just a few words, the right words. But in these windows of development, getting rich, nuanced, dynamic interactions could be more like learning a sport than just getting communication. And so I think these are really, really important questions
Thank you.
that need to be studied.
I could add on to just having done therapy during the pandemic and having to use telehealth got really creative. I mean, I'd show up with puppets and the kid would show up with a puppet and we would engage that way. There was a lot of scavenger hunts in their room about what are the things in their space that make them feel safe or seen or comfort level. So, I mean, as creative as I could be, and I think having been a teacher and knowing you just pivot and pivot and pivot was really, really helpful. But I played through the screen. I had dolls, I had puppets, and sometimes my teenagers, we were looking at the ceiling. But that's sometimes when you work with teenagers, not having eye contact and being in the car or going on a walk is amazing. So there are tools, and I just encourage you, if you have to do that sort of, you have to use a telehealth, be really creative.
I'd also like to add something. With telehealth, really the camera, paying attention to that is real, and looking into it, even though you may not be actually looking at them on your screen, as long as you're looking into your camera sometimes so they can really feel that you're there and that you're present, as well as making sure your space of whatever is behind you is also inviting and not kind of scary. You don't want a door right behind you, right? Because they're not in that room with you. They don't know what's behind that door. It can kind of create some sense of lack of safety, as well as in terms of with little kids, I would say getting really big and hi and stuff like that, tone, very important, just to really increase that engagement. And that's all I have to add about that.
Great, thank you. Those are all great. So this would be for each of the school-focused people. What would you like from your teachers to support both you and the youth you work with? Because I think there are some teachers here, yes? Yep. Yell out if you're a teacher. Yeah, okay, good, all right.
Can I
Go for it.
first?
Yes,
Yeah.
yes, please.
That's a tough question. I think that's something that we have a lot of friction. I mean, we both want the same thing. We want our kids to be successful. And I think teachers have a lot of pressure to make standardized testing, to make goals. And if a student's not in class, then it's kind of on them to help them catch up. So if I'm pulling a kid out of a math class or science class, then the teacher, I can feel some hesitancy from the teacher, or the teacher might say a certain amount of time. I think it's really about communication. I really make an effort to meet with teachers after school and share confidentially kind of what's going on with the student and why this is important. And I think, and I've been at my school for a while, so I think teachers really trust that my intention is good, that I'm not just goofing off with them, and we're not just playing games, but we're really working on goals. And so I think communication is key, and some flexibility, and we have to work together with teachers because it's not, that's the goal, right, is education in the school setting, and then providing mental health is kind of a secondary view, but it is what it is, and it is happening in real time. So teachers are being flexible, we're being flexible with them, so I think that's kind of the biggest, that's kind of the goal.
Great, thank you.
I love that, and I will kind of go off of that. I think openness to each other's perspectives, flexibility and curiosity, I feel like are so important. Like Steve was saying, sometimes it can kind of feel like there's opposing or just different viewpoints on what a student really needs. And I just really want to acknowledge that teachers have a really, really, really challenging job. There's so many things that go into being able to help students learn while also really managing 20 to 30 students' unique needs. Incredible. And so many behaviors happening, and even just having run counseling groups, having 8 or more students, I'm leaving school and my hair's like this, and I'm just like, oh God, do I want to come back? And it's a lot, and teachers come back every day and they really care. And so I think as much as we can assume best intent on both sides, sometimes there's teachers who come into my office and are really venting about a student that I deeply care about and see a different side of. And then me acknowledging that, well, they are, this kid was just throwing a chair at them, and that must have been really hard. And so like us just coming in and really realizing that we're part of the same team and care about the students' well-being and academic success, and figuring out ways that we can really be open to and integrate each other's expertise, because teachers have so much to offer, and many teachers have been at schools for decades and have a deep and intimate knowledge of how to help children succeed.
Thank you. Is that good? Because I realize I have like 5 questions and we have 3 minutes.
For 30 seconds?
Yes.
I deeply apologize because I pulled a slide not knowing there would be awesome teachers here. We have beautiful data to show that teacher-student closeness in 1st through 3rd grade really buffers the cortisol or stress response for kids who have domestic violence at home and interpersonal conflict. So I just want to give you a shout out, like you also buffer the stress biology. So it's those protective relationships across all these contexts, but you're a really powerful one.
Beautiful. Okay, so I am going to now really they're mainly for you, Nikki, but so a person commented on the cis heteronormativity, and that may be a mouthful, but cis means you're not trans, or you're just the sex assigned at birth, your gender aligns with that, and heteronormativity is assumption of heterosexuality. So in your research and in your presentation, there was really an assumption of cis heteronormativity. And also, so I'll give you a second to describe or to comment, but also only mentioning the trans experience in your slides as a stressor on the intersectionality slide. So can you just briefly comment on that?
Thanks for the question. It's always an opportunity to expand and grow on how things landed. I was trying to fit a lot in, you may have noticed. And I also have been conditioned for the last year and a half to really edit what I say, especially when things are being recorded, as I mentioned. A lot of our research, some of the stuff I highlighted started like 15 years ago when it was less common to ask more about gender identity. However, heterosexuality and partnership has always been asked, and I usually highlight it in all of my slides. And we do ask that of parents and caregivers. In the National Children's Study, I was part of the team that added gender identity, heterosexual identity, and preference, and all these pronouns, different things into the National Children's Study. And so I agree, it's incredibly important. It's a really big part of the story. In terms of focusing on it only as a stressor, I think 90% of my talk was focused on stresses and compounded stresses. And my goal in that intersectionality slide was not to highlight transgender identity as only a stressor, and I apologize that it landed that way for someone in the audience. My intention was to get us to recognize that power and privilege is on a continuum, and it really matters how many of those layers are either promoting resources and opportunities for advantage to seek support, resilience, et cetera, versus potential additional harms. And it could go either way. I know the transgender community, I'm close with many people within it, work closely with the transgender clinic at UCSF on my floor. And some of the folks in that community are some of the most authentic, empathic, empowered, social justice-oriented activists, and there's so many strengths in that community, and I do want to highlight that and make sure that it's clear that I believe that and know it to be true. And just want to name that, and also, a lot more adversity experienced in that community for a variety of reasons because of discrimination in their family and in the community, so they do tend to face a lot more stressors.
Thank you. And I really apologize to all of you who wrote these amazing questions because I didn't get to them all. There are a couple overlapping questions about the current political environment overriding science and how this might be impacting the dissemination of information and the impact on research. I think you spoke to that really eloquently already, but so this is a parallel. So we're all interested in that clearly. Also, how your science and what you're doing relates to policy and what all we can do to support the advancement and the advancement of science in this climate. And yeah, in 30 seconds. And Ron and Dr. Dahl, you can comment too if you'd like.
It's been a hard year. We're persisting. I think we've been able to rebound in lots of ways, and we've won a lot of battles this year. A lot of my grants and the grants of my colleagues got refunded after being canceled. We're able to do the work, some things less so, but we're persisting. This is not forever. It's for now, and I think in a way it's awakening us to the need for this work. I think the other piece around policy is please share the word, even with your friends, about the science we've talked about today and the solutions that the clinicians and interventionists around have shared, because I think there's so much stigma. We don't realize how many opportunities there are for support, or how even the relationship, just my friends' parents or my neighbors were such huge supportive buffers for me growing up. There's so much potential for supportive relationships across the board to buffer these impacts. And if we can get policymakers to do something to prevent this, often they don't see the economic benefit of these prevention programs we're promoting because they take years to see. And so someone who's trying to get reelected tomorrow is going to be less motivated. But if everyone in this audience called the same policymaker and said they really wanted to see support for these types of interventions, then all of a sudden they would be really interested in it. And also knowing about things like the dyadic care benefit, that came about because people kept showing the science to policymakers and insurers and saying, hey, this science is really compelling. Why aren't you funding this? And then they were like, oh, I guess we should. And then they're like, wait, maybe we'll save money. So communicate and share and give that message of hope, because I think the ACEs Aware campaign has been really useful in getting people aware of ACEs, but there hasn't been enough solutions on the table for people to feel really hopeful, and I think we need to spread the news of hope.
Thank you. And then on a sort of parallel note, we know that here in Santa Cruz, our local school districts are laying off mental health counselors, and if you talk about the importance of what we just saw today so poignantly, I think, the importance of our mental health counselors. What can we do? What advocacy do any of you as counselors have ideas of what we can all do to support you and support your positions?
Thank you so much for acknowledging that. I think so many of us in the room are really impacted by these cuts, and our students are as well. I know that at PBOSD, at Live Oak, and at Soquel, there have been cuts. In terms of advocacy, I think showing up as much as you can and as often as you can, and using your voice in board meetings, you know, with parents, asking them to use their voices too, to share the impact that the work has, and to really just continue to reach out even beyond that. Like, I've been reaching out to the state legislators and
Good.
putting comments on the California State Department of Education board meetings, just reaching out far and wide and trying to get the word out there that this is happening, and that these services are really vital. They shouldn't be optional.
Exactly. Thank you. All right, we're at time. Thank you so much, everybody. Thank you to our panel. Okay,
Jen, do you have any
Karen.
more questions? I'm going to, before anyone gets up, because I know
okay.
once
All
everyone
right.
gets up,
well,
I
okay.
will.
I'm going to spitfire here. Any adoption studies that look at the change of zip code impact on effects of adversity across generations?
I'm not aware of.
So I guess that's the original zip code, and then you change the zip code?
I'm not aware of adoption studies that have looked at zip code, but they have randomly assigned people to zip code, and there were some benefits, some drawbacks, moved them to opportunity, and it's a very complicated story. You move someone from their community where they know everyone and they're in the same income bracket, and you move them to a better neighborhood. That has some advantages, but also can be very stressful socially for a variety of reasons, so it's a mixed bag. There is, however, amazing data by Raj Shetty, who's an economist, to just show that just living across the street in a slightly better neighborhood can have huge earning impacts and life health impacts. And so there's lots of data to suggest that it can work. But of course, we should just make all of the neighborhoods more equitable, and then we won't have that problem.
Exactly. There we go. Thank you so much.